I can tell from the questions today that we've got some experts in the audience, but I hope it's all right if I start a little bit at the beginning for the people who might not be quite so expert and just spend a few minutes reminding ourselves of what we're talking about, what is ET and why is it a problem. Some of what I'm going to talk about today has been covered a little bit over the course of the other talks, so hopefully there will be some revision along the way, and for those of you who know it already, you can just rest your eyes for that bit. So I'm going to start by showing you some blood. This is what I look at all day long. And for those of you who haven't seen this before, the big red ones are the red blood cells. You can see in this field one of our different types of white blood cells. This one's got 3 little bits to its nucleus, which is the bit in purple. So that's what we call a neutrophil. They're very important for fighting things like bacterial infections. And then all of these other things in the background, these tiny little cells, are platelets. And as you know, ET is a problem of too many platelets. So why does this happen? So those of you who have had a bone marrow biopsy might prefer to forget the experience, but if you can manage to remember it, you might remember that we sometimes take out a liquid sample and a solid sample. So the first pictures here are of the liquid sample, the bone marrow aspirate, and this is a solid sample. And what you can see here is some very small purple dots in the background, and they're most of your cells in the bone marrow that are there to make your blood cells. And then these very large cells, and it's similar here in the trophine biopsy, small purple dots in the background, and these very large cells here. And these are megakaryocytes. Megakaryocytes are the cells that are there to make your platelets. And the way they do that is by budding off this purple stuff around the edge. That's called the cytoplasm, and that turns into platelets. So why am I telling you this? Because this is what goes wrong in ET. This is a relatively normal megakaryocyte, but as you can see, some of these other ones, this one, for example, here, is enormous. And I can tell you that this bit in the middle, which is its nucleus, is also much too big. And these are the kind of problems that we see in the bone marrows of people with essential thrombocythemia. Essentially, those bone marrow megakaryocytes are too big and they're making too many platelets. So fine, that's what happens, but why does it happen? So all of your blood cells are produced in your bone marrow ultimately by a small number of cells that are called blood stem cells. So this is a very small population within your bone marrow, and the important thing about blood stem cells is they can do 2 things. They can renew themselves, so they can go on to make more blood stem cells, which is very important because you need to be able to produce blood all the way through your lifetime. But they can also mature into many, many, many different types of blood stems, of other blood cells. So, for example, they might then turn into these slightly more mature types of cells that we call progenitors, and then these then go on to mature into the cells that we recognize in your blood. So here we actually have matured into a megakaryocyte in the bone marrow, and then into platelets, and then into white cells and red blood cells that then go out from your bone marrow into your blood. So in disorders such as ET, the problem is in one of your stem cells where something has gone wrong. What goes wrong? So this is due to damage in the DNA in one of those stem cells, and this is what we mean by mutation. So a mutation is just a change in the DNA in one of those stem cells. The DNA is the genetic code that is there to tell your cells how to behave. And so if you have a change in the DNA in one of the cells, what we end up with is altered growth and behavior of the cells in the bone marrow. And what we get in this disease is overproduction of blood cells. So what are the mutations that we're talking about? So hopefully these are now familiar to most of you. So in ET, around just over half of patients will have a mutation in JAK2, the JAK2 V617F mutation that we've already described. This is just a fancy picture of what it looks like when we test for it in the lab. Around 25 to 30% of patients with ET have a mutation in a different gene called calreticulin, which we test for in a different way. The minority of people have a mutation in a gene called MPL, which is an important protein that is involved in telling megakaryocytes when to grow. And then around 15% of patients, we don't identify one of these mutations, and we sometimes refer to those patients as having triple negative disease, which just means they don't have any of these 3 mutations. Is it quite that simple? Well, we know it's not quite that straightforward. So actually, this is, forgive the very long graph and it's a little bit complicated, but this is a study that was published by a large collaborative group of investigators led from Cambridge, but with collaborators around the world. And what we looked at here was actually a lot of different genes that we know can be abnormal in a range of different blood cancers. And we found that this is across all MPNs, not just ET, But you can see here that these are the different genetic abnormalities that we find, and you can see here that JAK2 and CALR and MIPL are definitely there, and they're definitely amongst the favourites. But there are other abnormalities that are found, so it's not just these ones that we find there. And in fact, in this study had more than 2,000 patients, and actually a good proportion of those had ET, so it's a good way of looking at patients with ET. So we know that other abnormalities can be found, but we don't tend to go looking for those in patients who have relatively straightforward ET. And the simple reason for that is, perhaps we alluded to earlier, it doesn't really tell us how to look after you, at least initially and when things are going in a relatively straightforward way. So we know that other things do go on, but we don't tend to look for that in everybody because it doesn't necessarily help us. So why is ET a problem? So first of all, you have an abnormal blood count. So for many of you, you might have felt completely well when you had this diagnosis made, or at least you might not have felt completely well, but not particularly unwell. And essentially you had a blood count for a completely different reason, and your doctor told you that your blood count was very abnormal and you had to go and be investigated. So it's very common that this is found as what we call an incidental finding. You had a blood test for some other reason, but now it's a problem because we've identified your abnormal blood count. So we know there's an increased risk of what we call vascular events. Vascular events means problems in the blood vessels, either blood clots or bleeding. So this is a CT scan. I'm not a radiologist. Fortunately, I'm married to one, so he can tell me what the problem is. So this is a CT scan of a patient's abdomen. So when you look at a CT scan, it's like you're looking up through the patient. This is the spine, and this is the patient's liver, and this is the patient's spleen. And I can tell you that both of those organs are far too big, and they should be a nice smooth grey colour, whereas you can see they're all different shades of grey, and that's because that patient's had a big blood clot in one of the blood vessels coming out of the liver. We've talked a lot today about symptoms, and we know that ET, as with all the MPNs, can significantly be associated with symptoms. And then we know that, fortunately, the minority, but there are definitely a proportion of patients where the disease can change into something more concerning. So one of those conditions is myelofibrosis. So this is another picture of a bone marrow trophine biopsy, which has been stained in a different way. And this is particularly to look for fibres in the bone marrow that tell us about bone marrow fibrosis. So this bone marrow has more fibrosis than it ought to. And then this picture is of some bright blue cells, which are called blast cells. And those are the cells that we look for when we're looking to see whether a patient has developed leukemia. But one of the things about ET is that really this is a disease that is very, very variable. So every patient is different, and they can be very different. So, for example, your risk of having a blood clot is very, very different if you're in your 20s as compared to if you're in your 80s. Some people who come into clinic have already had several heart attacks and a stroke. Others have never thought about having a heart attack or a stroke. And when we look after people with ET, we need to take everyone as an individual and manage them accordingly. So how do we do that? We've got to think about what our aims of treatment are here. So one of the things that we concentrate on is trying to prevent what we call vascular events, so blood clots and bleeding events. We would like to do better at relieving symptoms, something we've talked a lot about today, be it fatigue and other problems such as headaches and itching. We would like to reduce the risk of disease transformation, and that's something that probably is a bit of a weakness in our treatments at the moment, and that's something that we'd like our therapies to do better in future. There are some special situations that we have to look after, and one of those in particular is young women in pregnancy. So ET is probably the commonest disorder that we see in younger women, and that's something that we have to look after in particular ways. What we don't want to do is to make people feel worse as much as we can, so we have to minimise the side effects of treatment as much as we can, and we have to do our best to look after the emotional and psychological well-being of our patients, and you've talked a lot about that this morning as well. So what I'm going to talk a little bit more about today is trying to prevent the thrombotic and bleeding events, and that's because that's actually the thing that our medical treatments are better at. And really, a lot of what we try to do here is to try and tailor that to the needs of an individual, because as I've alluded to, those risks are very, very different between different individuals with ET. So what do? So we make our diagnosis. Sometimes we do a bone marrow biopsy, sometimes we don't. And then we do what's called risk stratification. So what risk stratification means is your doctor trying to work out how likely it is that you might suffer a vascular event. So either a clot, or thrombosis, as we might call it, or a hemorrhage or a bleed. And the difficulty here is that we can't tell you as an individual specifically what your personal risk is, but we try to put people into broad risk categories that helps us give us an idea of what the most appropriate treatment might be. But we can never tell you as a specific individual what your exact risk would be with or without a specific treatment, and that's what can be a little bit hard. So then we try and work out what would be the best treatment to recommend to reduce your risk of having a blood clot or a bleed, and broadly the things I'll talk about will be aspirin and then drugs to reduce the platelet count. So how do we do this? How do we identify the people who are at higher risk of having these vascular events? So over the course of having studied ET, the criteria that have come up to identify people who are more at risk of having a thrombosis, a blood clot, are essentially people who are over the age of 60 and people who have had anything in the past, so a previous thrombosis or a previous major bleed that's been attributable to their disease. And those are the people who we recommend to have some kind of drug to reduce the platelet count. We also tend to recommend drugs to reduce the platelet count in people who have a platelet count more than around 1,500. And the reason for that is not so much because that increases the risk of thrombosis. Interestingly, there isn't really a clear correlation between a very high platelet count and the risk of thrombosis, although you might think that there would be. But what there is an association between is a higher platelet count. So this is a graph from one of the studies we did in called the PT1 study. So you can see here that as your platelet count increases along the bottom here, the risk of bleeding goes up. So the reason that we recommend treatment for people who have a very high platelet count is if you don't treat those people, they're actually at increased risk of bleeding. Can we do any better than those factors? Well, there have been some other suggestions as to risk factors that we might take into account. And I mentioned JAK2 mutations earlier. So there's another score that was that's been brought out called the IPSET thrombosis score. So in case people have read about this, so this subdivides people further according to whether they have a JAK2 mutation or not. So if you're under the age of 60 and you've never had a thrombotic event before, then this would divide you further into low or very low risk according to whether you do or don't have a JAK2 mutation. And if you're over the age of 60 and you've never had a thrombosis, into high or intermediate risk according to whether you've got a JAK2 mutation or not. And if you've previously had a thrombosis, then we always consider you at higher risk of having a thrombosis. And some investigators have suggested some treatment recommendations according to this scheme on the right. In particular, one of the major questions is whether if you're in this very low risk category, so this is really younger people, often with a CALR mutation, whether or not you necessarily need aspirin. Perhaps not everybody does. Having said that, this particular scheme on the right isn't universally accepted to tell us what the treatments should be, so not everyone is using this system on the right, and that's because it hasn't quite been validated in the same way as the scores on the left. So let's talk a bit more about treatment. And this is just a reminder for me to mention something else. So this scan on the left-hand side, this is a brain scan. And again, this area at the back of this patient's brain, so these are the eyes at the front, this is the back of the brain. This should all be a nice smooth grey colour. And unfortunately, this patient has had a stroke. So this is there to remind me that if you ask somebody off the street what causes people to have strokes, they won't say ET, but they might mention things like smoking or diabetes or high blood pressure or high cholesterol. And it's just as important for us to be looking after your ET as it is for you and your primary care physician and us to be looking after all the other things that are important for your blood vessels. So that includes not smoking, somebody keeping an eye on your blood pressure, managing your high blood pressure if you've got it, same with diabetes, same with high cholesterol, making sure you get some regular exercise, and keeping an eye on your weight. And all those things are also very important. So aspirin. So to remind you, aspirin is a drug that does not reduce the platelet count, but the way it works is to affect the platelet function so that your blood is clotting less effectively. So the reason that we recommend aspirin in ET is because there was a clinical trial now quite a long time ago in the related condition, PV, in which we found that aspirin reduced the risk of blood clots without any increase in bleeding. And because PV and ET are closely related, there has been a recommendation that we also use aspirin in people with ET. There are still some questions about aspirin that we're not completely sure of in ET. So one of those is whether everybody with low risk ET really needs to be taking aspirin. And the question is probably most around people who have the CALR mutation rather than the JAK2 mutation. No one quite knows the answer, but particularly for people with very high platelet counts who are younger with a CALR mutation, there's a question as to whether everyone should definitely be on aspirin. There's also a question which is currently being looked at in clinical trials as to whether, if you're in a high-risk group, whether actually just having that once daily aspirin is definitely enough. So there are some suggestions that because the platelets are turning over very, very quickly, so you're producing lots and lots of platelets, whether that can almost make you slightly more resistant to aspirin than the average person who's got a normal platelet count. So I think most people probably aren't changing any practice based on that so far, but there is this research trial that's currently going on asking whether actually patients with ET should be taking aspirin twice a day or even 3 times a day. But that's not something that we've introduced outside the research study at the moment. So drugs to reduce the platelet count. So we've said who needs these drugs? People over the age of 60, people who have had a previous blood clot, previous bleed, or a very high platelet count. We do sometimes use them for other reasons. So if someone has not strictly got all of those things, but if you have lots of other risk factors for example, heart disease, if you're JAK2 positive as well, sometimes there can be a lot of things that seem to be stacking up that suggest that maybe you're better off being on a drug to bring down the platelet count. And then also if you don't have those things, but if you have very bad symptoms, such as very bad headaches or itching, then sometimes we suggest a trial of treatment to see whether that can improve the symptoms. But aside from that, most people who are under 60, who haven't got a previous blood clot or bleed, who have a platelet count less than 1,500 and don't have anything else complicated going on, most people wouldn't need one of those drugs. And that's recently been tested in a good trial that we published last year, showing that we don't think that we need to add in something like hydroxycarbamide in that situation. So what are our options? So we've mentioned all of these so far today. So hydroxycarbamide, interferon alpha, and agrolide. Typically, after we've tried one of those in a smaller group of patients, we might try busulfan, and probably less commonly, again, drugs like pipabroman or radioactive phosphorus. I'll mention ruxolitinib in ET, and that's been mentioned already, and I'll just mention drug trials as well. So what are our options? So hydroxycarbamide, so this is still very often the first choice of therapy, and one of the reasons for that is of all of our treatment options, it probably has the lowest rate of side effects. So this was the study that was published back in 2005, which looked at patients with high-risk ET and directly compared so tossed a coin between taking hydroxycarbamide and an agrolide. And what that study found was of those two therapies, hydroxycarbamide was associated with fewer blood clots or bleeds, less transformation to myelofibrosis, and overall fewer patients had to stop their treatment compared to an agrolide because of side effects. So that's the reason that we tend to use hydroxycarbamide first line in many people. There have been some questions asked about the long-term risks of hydroxycarbamide, so some questions in the literature about whether it might contribute to a risk of leukemic transformation, but that's never been proven, and we still consider this in general to be a safe drug. We've talked a lot today about interferon alpha. Certainly this is the safe drug for pregnancy, and it is increasingly used. I've said here often in younger individuals, but as Jean-Jacques would tell me, of course it's perfectly fine to use it in older individuals. It does have a side effect profile, but as with all I haven't gone into great detail about side effects because the fact about side effects is that they're different between different individuals. So you kind of have to see what you get. So this is just an example of some of the recent data from the MPDRC111 trial, and I've included this because it includes patients with ET. So this is a study that looked at patients who had already tried hydroxycarbamide and were either intolerant or resistant to that. And overall, around 70% of the patients in the study with ET were able to get some kind of response. So that means at a minimum, their platelet count had got down to less than 600 after a year. As Jean-Jacques mentioned, one of the attractive things about interferon is that we see, at least in some patients, what are called molecular responses. So that means that when we measure the proportion of cells in the blood that have the JAK2 mutation or the CALR mutation, that seems to decrease over time. And that's certainly very interesting. It's it's an attractive phenomenon, although we don't quite know what it means in the long term. And as he mentioned, there are these studies underway comparing hydroxycarbamide to pegylated interferon, though they haven't yet been published. And one of these has led to the licensing of the ropeg interferon drug. Just to mention that that is in PV, as he mentioned, and also just to mention that just because something is licensed does not necessarily mean it's automatically available. So it has to be funded before it is available. What about anagrelide? So as I've said, we tend to use that second line. It's a drug that's more selective for platelets. So if you're struggling with your blood counts being suppressed by hydroxycarbamide, it can be helpful because it tends to, on average, just bring the platelet count down. On average, it has slightly more side effects than hydroxycarbamide, but again, every individual is different and will get different side effects or none at all. And on average, again, it has a slightly higher rate of bleeding and fibrosis, but it can be quite useful second line. And then these other drugs, busulfan, pipabroman, radioactive phosphorus, again, these can be quite useful. They do have some longer term risks, so we tend to use them in a smaller group of patients. I just want to briefly mention treatment targets. I think there was a question about this earlier. So what are we really aiming for with our treatment of ET? And this is one of those, we talked a little bit earlier about evidence and guidelines. And this is one of those areas where we don't have the best evidence to tell us what we should necessarily be aiming for. So if you look at the guidelines, it will tell us that we should try to aim for a normal platelet count in ET. And that's based on the fact that the studies that have been done have aimed for a normal platelet count, so we think that that's a very reasonable thing to do. But sometimes it can be very difficult to get a normal platelet count without giving you side effects, and the question is what we do in that situation. So one option is to relax the platelet count target a bit, so a normal platelet count would not generally think of as less than 400. One of the earlier studies in ET actually aimed for a platelet count of less than 600, and the rate of vascular events wasn't too bad. So sometimes we relax that platelet count down to a little bit to perhaps 600 in people who haven't had problems with vascular events in the past. I mentioned that there will be some people who were treated purely because their platelet count was more than 1,500. And if we've only treated you because your platelet count was more than 1,500, and we were perfectly happy when your platelet count was 1,400, then arguably we shouldn't really need to get your platelet count down to 400 to be happy. That doesn't really make any sense. So I would argue in those individuals, we don't necessarily need to aim for a platelet count of 400. If we're only treating you because you've got symptoms, that's the only reason to treat you, then the target should be to stop your symptoms, not necessarily to have a perfect blood count. And then the other question is for individuals with a high white cell count, whether we should be trying to get a normal white cell count. And the honest answer is we don't know whether that's something that we should be aiming for or not. And then the other question is about molecular responses. So should we be trying to reduce the level of, for example, the JAK2 mutant cells in the peripheral blood? Is that a good thing to aim for? And intuitively, it sounds like a very good thing to aim for. But we do also know that, for example, there have been patients in whom they have seen reductions in JAK2 allele burden, but still those patients have, for example, their disease is still transformed. So we don't know for definite that that's a perfect target to aim for. Just briefly to mention ruxolitinib in ET, so I think this has also been covered in Adam's talk. So this is, as you know, this is a JAK inhibitor. It's been licensed in myelofibrosis and polycythemia vera, and this was studied in the MAGIC study in ET. So it was compared in individuals who either hadn't responded to or didn't tolerate hydroxycarbamide, and was compared with best available therapy, and found in terms of controlling the blood count, it wasn't any better than those other best available therapies. Having said that, it can still be quite useful for certain symptoms, so things such as itching, and we can still get hold of it fortunately through a compassionate usage scheme in the UK. So we do still use that. So where next? So just a few things to mention, and again, Adam mentioned the Tamarin study already. So this is really, again, trying to find some agents that do what we really want to do, which is attack the underlying cells that are causing the disease. So the Tamarin study came about as a result of these very interesting scientific studies, which I will not go into detail about. But essentially, some scientists who actually work on estrogen biology. So we think about estrogen as a female hormone, but actually everybody has estrogen. And it turns out that estrogen signaling is important in the production of normal blood cells. And the work that they did here was to find that if you put estrogen, if you put tamoxifen, which is a drug that we've used for many years in breast cancer, and expose it into cells that have the JAK2 V617F mutation, those cells seem to be selectively sensitive to it and die. So the question here is, in our recent trial in the UK, was if we add tamoxifen to the treatment of stable patients who have an MPN, can we reduce the proportion of cells that have the JAK2 or CALR mutation in the blood? And we've recently recruited that, so we look forward to seeing the results next year. What about new drugs? Nice sciencey slide. So the reason I'm showing you this is, again, just to try and show you that we're just seeing whether doing things differently will help. So I've shown you a picture of DNA, but actually we often show DNA as this double helix, but it doesn't really look like this in cells at all. So when DNA is in cells, it's actually closely associated with lots of other proteins, and the importance of those other proteins is to help the cell know whether the different areas and different genes in that DNA should be active or not. So it's wrapped around these proteins that are signified here by these little green cylinders called histones. And histones and their little tails, which are shown here in black, then interact with a whole load of other different proteins that modify it to tell the genes whether to be active or not. And the reason that's important and interesting is that these other proteins that then interact with those histones, that original graph I showed you at the beginning, which showed the other mutations that we found in blood cancers and indeed in MPNs, those mutations affect genes that affect this kind of signaling. So we're interested to know whether, by using drugs that can affect these processes, whether we can actually affect the underlying biology within these conditions. So just as a couple of examples as to how we might do this, there's a class of drugs called bromodomain inhibitors, and one of these, CPI-0610, is currently being tested in an international trial in myelofibrosis, including in the UK. And there have been some evidence that this may reduce the spleen size, reduce symptoms, change bone marrow fibrosis, and reduce transfusion requirements. And as part of that, we can see that the drug actually reduces platelets, so that's a good start for planning a study in ET. And then another class of drugs, these ones here, lysine demethylase inhibitors. And again, this is a specific agent, bomedemstat, which has shown some evidence of safety in patients, and as well in a mouse model of MPNs has shown some evidence that it may change the disease. So we're planning a study next year in high-risk ET. So just to finish off, I think one of the most important things about looking after people with ET is to remember that everybody is different. And really our treatment involves looking at an individual's risk and their symptoms and then trying to tailor our treatment as much as possible. We could definitely still do better. We would like to ideally be able to tailor our treatments, particularly to the risk of disease transformation, so that we can prevent those really distressing events happening. But I think actually for the first time in really quite a while, some new drugs are on the way. So I think we live in exciting times.